Hello guys, I am Dr. Mukul Mohindra, your orthopedic instructor here at Medway, and I am here to give you a quick outlook of this NEET-PG exam that was just conducted a day back. So the idea here is to just have a recall of the MCQs that came up in the exam and know your mistakes. So once you know and understand your mistakes, you become far superior in your further attempts. That is the whole idea. And I hope you guys are able to hear me and you are able to comprehend me, my voice, my audio visual part is all okay. Please just let me know. You can type up in the chat box and let me know if the audio visual part is all okay. Yes, please. I hope that's all fine. So okay, so I'll just get started and I'll just give you a brief outlook about this orthopedic section in the NEET-PG that was just conducted little time back. So this exam had a lot of orthopedics this time, uh, quite unexpected, and they were all questions that were testing, your basic concepts in the subject rather than the hi-fi questions. Images were there, clinical questions were there, and integrated questions were there. So it's just the kind of preparation, the board is making for the upcoming next pattern. That is what I suppose. So this question, a man, who's landed up in the emergency with a back pain, there's no deficit, but an x-ray was shown and you were supposed to pick up what is the fracture. What I have heard that there was a transverse fracture line bisecting the vertebra from front to back was shown. So if there was a transection of the whole vertebra from front to back, then it was likely a case of a chance fracture. Now this x-ray of a supracondylar humerus fracture was shown where this fragment had gone back. So that was Gartland type 3. Supracondylar humerus fracture, the distal humerus fracture is a fracture in children. The distal fragment is pulled back by triceps. If it is undisplaced, it is type 1 fracture. It is just angulated, it is type 2 fracture. If this distal fragment also goes back, it is type 3 fracture. So that was Gartland classification for supracondylar humerus fracture. Now there was a picture of a child with this kind of a deformity. We call it the windswept deformity, because if you see this knee, it is going into valgum, but if you see the other knee, it is going into varus. So varus at one knee, valgus at the other, that is windswept deformity. Windswept deformity is classically seen in rickets, but examiner was talking of recurrent infections, some abscesses the patient is developing. So perhaps hypophosphatemic rickets would have been the best pick. Hypophosphatemic rickets is related to an abnormality in this fibroblast growth factor receptor 23, and when this is defective, there's a signaling defect affecting immunity, and this often leads to recurrent infections and immune issues. So that is how this seemed to be the best answer. Okay, otherwise you had the classical features of rickets. Calcium was low normal, phosphorus was low normal, okay, PTH normal, ALP high. Now hypophosphatemic rickets, so phosphate goes into urine, so in the serum there is hypophosphatemia. So phosphorus low was another thing that was pointing to you this is hypophosphatemic rickets. Okay, now 16-year-old boy, he's claiming he's 18-year-old. So you have to estimate age. So with the Olympics around the corner, this was just the perfect question to be put into the NEET-PG exam. So if bone age is to be estimated, there are different methods we depend upon. Me being a sports medicine specialist, uh, you know, uh, quite often we face this challenges of bone age estimation, and these are the methods I generally employ: the Tanner-Whitehouse method, the GP method, the Fishman method for estimating the bone. Now, Tanner-Whitehouse is the most popular method, most accurate method, and it is based upon wrist and hand radiographs. Wrist hand are the predominant radiographs that are used. I don't know whether that option in the exam was hand only or was it knee, but this seems to be the best pick because predominantly this method is based upon short bones in the hand and the wrist. This is that implant that needs a spot diagnosis. An intertrochanteric fracture in this area of the femur is generally fixed with this implant, and this is a dynamic hip screw. I teach very clearly about this in my classes, And I think the people who attended my classes, the moment they would have seen it, they would have very well known that this is a dynamic hip screw used for intertrochanteric fractures. Now it was mentioned that a patient has pain going on the back side of the thigh and the leg. He lifted some heavy weight, developed this up. So it seems to be a case of a disc prolapse. You have to, which spinal segment is involved, you have to pick it up. So very simple. This is based upon the distribution of the dermatomes. A spinal segment will give rise to a spinal nerve, and that nerve will end up supplying a particular area of the skin. That area of the skin supplied by that nerve is its dermatome. Now this back side is the posterior most side of the body, and the sacral dermatomes run in this area. So back side of the leg and calf is S1 and S2. So S1 would have been the best pick in this case. Clear? Now an above elbow cast has been put up in a child. She's landed up with a cubitus varus deformity, and cubitus varus deformity is also popular as the gun stock deformity. And I think even a child knows, the cause for a cubitus varus deformity is supracondylar humerus fracture. So that was the site of this injury here, and you've already seen the X-ray of a supracondylar humerus fracture in that Gartland classification. Now there's a fracture at the base of the fifth metatarsal, and a below knee cast has been put up. Now fracture at the base of the fifth metatarsal is that very popular Jones fracture. You have the peroneus brevis muscle here, that's pulling this fracture away. So you need to give adequate immobilization period. Normally the immobilization periods we give is 3 to 4 weeks, but here it is almost double, 6 to 8 weeks. So this would have been the best pick. Normally it will be 3-4 weeks in most fractures, but Jones, because of this tendency to pull, 6 to 8 weeks would be the best pick. Now sports injury. Olympics around the corner, so of course you had to get questions on sports injuries. A football player, he's twisted his knee and ankle, he's injured some ligament in the knee, examination is being done, this test was shown over here, the examiner is pulling this leg in front, and the knee is in almost 20-30 degree of flexion. So when this 20 degree of flexion is there, the test is called Latchman test. Had the leg been bent to 90 degree, it would have been anterior draw test for ACL. So ACL injuries are commonest injuries in such scenarios, and the Latchman test is classically depicted in this picture. Fracture at which site would disrupt the longitudinal growth of the bone? I don't think I need to tell you, this is the growth plate. That's also called epiphyseal plate or growth plate. That's also called as physis. It has a number of zones that are involved in growth of the bone in a longitudinal fashion. So if anything happens with this growth plate, the longitudinal growth of the child is going to be affected. So that was the answer over here. Now a patient is unable to make the OK sign. So which muscle is involved? So for this you need to know what is chylonevine sign. This is a sign that you see in anterior interosseous nerve injury. Now anterior interosseous nerve is a branch of median nerve in the forearm. Now when this AIN is injured, which is a branch of median nerve in the forearm, it is generally injured by the pronator teres muscle in the forearm, or the flexor digitorum superficialis arch, or biceps tendon aponeurosis, that is laceratus fibrosus edge, or by an accessory muscle. Sometimes the accessory head of the FPL is there, that is Ganser muscle. So these are the injury factors for anterior interosseous nerve. Now these patients have only motor deficits generally, because AIN is a motor nerve, and they classically fail to make this OK sign. This is what is chylonevine sign. When you can't make this OK, like I have shown over here, this is because with FPL gone and FDP gone, the interpharyngeal joints cannot flex. So this interpharyngeal joint flexion goes. So rather than making OK, they make a peacock. So when they make a peacock instead of an OK, that is chylonevine sign. So that was the answer here. This was all about AIN syndrome, and FDP muscle and FPL are gone. So FDP was the best pick out of these options. There is a fracture shown over here. It is marked. Which area of the bone is fractured? So it's the lateral condyle of the tibia that has the fracture. Please, it's not fibula having the fracture. Very commonly this lateral condyle of tibia fractures, and that is called a Sigond fracture. Sigond fracture is a fracture often seen in cases of ACL injuries. ACL injuries occur because of twisting of knee, and because of that twisting of knee, the capsule pulls in this area, breaking the bone, and that is what is second fracture. So with Olympics around the corner, a lot of questions on sports injuries. So this is all about second fracture, which I very well teach in my classes as well. Now maybe some MRI was shown, and you could see some disc going back, like this is L5 vertebra L4, so this is L4 L5 disc going back. You have to pick up which nerve would be injured. So when a particular disc will go back, like this is L4 vertebra, this is L5, so if this L4 L5 disc goes back, the nerve that will always be involved will be the lower level, like this is L4, this is L5. If L4 L5 disc goes back, L5 nerve will be involved. So in a disc prolapse, it is always lower level nerve that is involved. So if this is L4 L5, it is L5 nerve that is involved. I teach this in detail in my classes, this whole anatomy around the spine and how a disc involves a particular nerve and how to pick up neurological deficit. So to understand the detail, go and watch my classes. Okay. Now child with femur fracture got the fracture plated. So what kind of healing would you expect? Suppose you graft a bone defect. The healing in grafting will be by processes like creeping substitution, bone apposition. You use cortical bone, it will fix in the grafting place by bone apposition. You use cancellous type of bone in bone grafting, it will fix by creeping substitution. But this primary and secondary callus, primary and secondary healing are the methods of bone healing in different scenarios. So these are the methods of bone getting set in grafting sites. Primary and secondary are the methods of bone healing after a fixation. If you fix with plates, what you get is primary healing. Here you don't find any callus formation on X-rays. If you fix bone by nails, what you get is secondary healing, where you find bone formation in the form of callus. So if you see callus, it is secondary healing. If you see no callus and bone is healing, it is primary healing. Primary healing mostly in platings, secondary healing mostly in nailings. Clear with that? And this one, a spotter, a tumor in the diaphysis, a round cell tumor on the biopsy, that is classical Ewing sarcoma. Ewing sarcoma classically carries this translocation 11 to 22. Just a repeat question from many previous exams. And in the end, you have to just pick up the level of the amputation over here. So this is knee, this is leg, so this is below knee amputation, or maybe transtibial. So just have to look at the choices and you have to pick up the answer. So these were the questions I could gather from the recall. The exam was simple. If you're clear with your basics, it was very easy. If your basics were not thorough, it was a difficult exam. But a lot of questions on the current scenarios around you, Olympics going on, a lot of sports injuries, and a lot of orthopedics, and a lot of orthopedics based on anatomy and radiology, and other integrated areas that are often clubbed with orthopedics. So I hope I've given you a hint about all the questions. We'll keep covering these topics in detail as we go through the classes. So catch me up on my classes on Medway. All the best to you. Bye bye.